Hi folks. So in this lecture we'll briefly discuss some common wrist and hand injuries that you may come across. For your DM part 1, you need to be able to describe an X-ray of the wrist, including naming the carpal bones. Some are more significant than others. So for example, of course, we must know quite a lot about the scaphoid bone and its blood supply, and the fact that when we have fractures of the wrist of the scaphoid, the proximal end of the bone tends to suffer with avascular necrosis, or can suffer with avascular necrosis, because the blood supply is from the distal pole. The triquetral bone is the second commonest bone to be fractured in the hand, but the fractures are usually quite minor and usually just present as a small avulsion fracture seen on the dorsal aspect of the wrist on a lateral X-ray. And of course, the other common injury you get in exams is lunate and perilunate dislocations and their complications, including acute carpal tunnel syndrome. We also need to think about the bones of the hand and how they articulate with the wrist, so the metacarpal bones, the phalanges, and the intervening joints. So let's start with somebody who's fallen on the outstretched hand. Very common injury in older people, the Colles fracture. Consider what are the main elements of a Colles fracture. You need to be able to describe what are the anatomical evidence of a Colles fracture. These would include dorsal displacement, dorsal angulation, radial displacement, radial angulation, and impaction. When you look at this X-ray, there's a real importance in terms of deciding whether the fracture is adequately reduced. So we look at the dorsal aspect of the radius here and the distal end which is displaced. If this angle is more than 15 degrees, then the hand is not adequately reduced. The articular surface of the radius usually faces this way. It's tilted in the volar aspect at 15 degrees. And we don't want that articular surface to be anything more than at right angles to the axis of the radius. So as we discussed, the deformity includes impaction, dorsal angulation, dorsal displacement, radial angulation, radial displacement, and the degree of supination, and therefore the manipulation involves the reverse. So we apply traction to disimpact, then we pronate and angulate the angle, the wrist in a volar direction with some ulnar deviation. Scaphoid fractures are caused by a fall onto the outstretched hand. They're less common in children. Remember, they may not show up on X-ray initially and may be associated with other serious carpal injuries. So if we have somebody who's suspected of having a scaphoid fracture, for example, they have tenderness over the scaphoid area on telescoping of the thumb, or tenderness over the snuff box, then what we tend to do is put them in a plaster. Traditionally we talk about a scaphoid plaster, but we can use just normal splints such as a back slab or a thumb spiker. We re-X-ray in 14 days, and if this is inconclusive or the symptoms persist, we may do further investigations such as an MR scan. Complications may include non-union or avascular necrosis. Here's an example of a scaphoid fracture, and the picture on the right shows the blood supply to the scaphoid bone. Remember that scaphoid injuries may occur in isolation or may be part of a more extensive wrist injury, such as a perilunate dislocation. So once you see a scaphoid fracture, look for abnormalities of the other wrist bones. The perilunate dislocation arises from a fall onto the outstretched hand. And again, it may be associated with other injuries such as scaphoid fractures. The X-ray shows the radiological features of a perilunate dislocation with the empty cup sign. The concave part of the scaphoid does not hold the capitate anymore. This needs urgent reduction and splintage and may be associated with carpal tunnel syndrome, or, because it causes quite significant swelling, may cause compartment syndrome as well. And here is the triquetral fracture that I had spoken about earlier. It is the second commonest fracture of the wrist, may be associated with a fall onto the outstretched hand, and is often missed because it's so subtle. Let's talk a little bit about fractures of the thumb. So the Bennett's fracture is a fracture of the base of the first metacarpal due to a hyperextension injury of the thumb or a fall onto the outstretched hand. It can be a very unstable fracture because the adductor pollicis, the abductor pollicis longus, attaches to that part of the thumb, and with avulsion, the thumb joint, that the carpometacarpal joint of the thumb, becomes unstable and tends to sublux. So this can be treated with a Bennett's plaster, but often needs internal fixation. The gamekeeper's thumb is caused by hyperextension or abduction of the thumb at the metacarpophalangeal joint, and is really due to either tearing of the collateral ligament at that point or avulsion of the ligament attachment at that point. A partial tear can be treated conservatively, but a complete tear needs repair. A complete tear, if you anesthetize the area and then you apply an abduction force to the metacarpophalangeal joint, if there is no resistance to the force applied, so the thumb just continues to bend, that is a sign that you have a complete tear and that needs repair. You're going to see metacarpal fractures. Remember the significance of the Böckcher's fracture. So a fracture of the neck of the fifth or fourth metacarpal with a small laceration. People often don't tell you the truth about the mechanism. The thing is that these injuries can cause implantation of germs and bacteria into the MPC joint, the metacarpophalangeal joint, yes. And this may not be noticed because the injury occurs when the joint is flexed, so the hand is held in a cuff, and you examine the joint when it's extended, the hand is held extended, and therefore the laceration into the joint doesn't line up, so it appears to be a superficial laceration. These need very careful examination, cleaning, and antibiotics. Exploration, there should be a low threshold for exploration in these injuries. What we do with fractures of the shaft depends on angulation, and the next slide will show this. So this X-ray on the left is an oblique fracture and is at risk of angulation. This kind of displacement obviously needs reduction. And this is the Boxer's fracture we talked about before. Let's think a little bit about this oblique fracture. So when the patient presents with their hands open, you may not notice the rotational deformity. But if you ask them to make a fist, the fingers overlap, and that may lead to severe disability. Therefore, it's really important when you have somebody with a metacarpal or a phalangeal fracture that looks rotated, ask them to make a fist and make sure the fingers don't overlap. If they do, then this needs reduction. Let's talk a little bit about phalangeal injuries. They may be due to hyperextension, rotation, or stubbing. We talked about the significance of the rotational injuries in the last slide. Generally, we need to reduce them and splint them. Body splinting or splinting to the adjacent finger is usually sufficient. There are some specific injuries we need to think about. So let's just look at these. Here is the mallet finger. This is due to an avulsion of the insertion of the extensor communis tendon into the base of the distal phalanx, or a rupture of the tendon, and causes drooping of the finger. The deformity itself may present a few days after the injury, and the treatment is a mallet splint, which is basically a splint in extension of the DIP joint. The other injuries you might see are the swan neck deformity or the boutonniere deformity. The boutonniere deformity is a rupture of the extensor communis expansion over the proximal interphalangeal joint, which causes the joint to flex and push up through the tendon. You need to know the anatomy of the fingertip, including the pulp, which is very sensitive, the nail bed or sterile matrix, the germinal matrix. This is where the nail grows from, and then on this side, which is not shown, the tendon of extensor communis, and on this side, the tendon of flexor digitorum profunda. So you need to know this. You also need to know a little bit about amputations of the fingertip. With a fracture of the tuft, you may get subungual hematomas, which need to be trefined because they can be very painful. Of course, if it's fractured, you need antibiotics as well. Fingertip injuries may present like this, and it's really important to look to see if the base of the nail is avulsed, and if it is, it needs to be replaced, usually by removing the entire fingertip. If this doesn't happen, a new nail will start to grow back from the germinal matrix, and you get two nails trying to grow at the same time, and subsequent deformity. So this is a little bit about subungual hematomas. Amputations. The treatment depends on the degree, and these things can actually be classified. If only the pulp is involved, that is called a grade 1. If it's a pulp plus a little bit of the phalanx, it's grade 2. A little bit of the nail is grade 2. Bone is grade 3. And then finally, if we get way back to the back of the hand, that's grade 4. Finger. You need to know the classification of fingertip injuries. The reason we classify is to decide on treatment. And here we have the zones and the types of injuries you might see. Like I said, there are 4 classes of injury. A little bit about how we can repair, we can talk about this later. So in conclusion, hand injuries are common and a good functional